We have lots and abundance of safety data for SGLT2 inhibitors. And because they're single dose, they're just so easy to implement in real world practice.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. Thanks for tuning in. I have the distinct pleasure of having with us Dr. Shelley Zieroth. She's professor of medicine, a clinician-scientist, and an advanced heart failure and transplant cardiologist in Winnipeg, Canada. And we're going to talk about SGLT2 inhibitors in cardiovascular disease. And we were just having this conversation offline that it just so happens to be the 10-year anniversary of EMPA-REG, which introduced empagliflozin to the cardiovascular disease space. And our guest, Dr. Zieroth, is actually traveling to Vienna for that celebration. So with that introduction, without much further ado, Shelley, welcome on the show. And thank you so much for doing this for us.
Oh, thank you so much, Ankur. It's such an honor to be here. I love your podcast.
Oh, thank you. Thanks for being a listener. Thanks for tuning in. And thanks for being a guest. The honor and the privilege is ours. Shelley, educate us. 10 years, it sort of has changed. The SGLT2 inhibitors have completely changed the landscape for many things in cardiology. But, I should stop talking and have you start talking as the expert. When did this all start?
It's been, for me, I think the journey really did start with EMPA-REG outcome. It was really, I think, the landmark clinical trial that sort of moved SGLT2 inhibitors beyond the anti-hyperglycemic space. And it's part of the reason, like you said, I'm going to Vienna to celebrate with endocrinologists and nephrologists as well. And, I think as a whole, SGLT2 inhibitors really have become a pillar of cardio-kidney-metabolic medicine. But I'd say EMPA-REG outcome was the big one for me. That was in 2015. It was a couple years before I became president of the Canadian Heart Failure Society at that time. And I just remember, these were trials, cardiovascular outcome trials designed to ensure that anti-hyperglycemic agents like SGLT2 inhibitors weren't causing harm, right? We had some signals in other therapeutic, medications with type 2 diabetes that were causing cardiovascular harm. I don't think anybody expected EMPA-REG to read out the way it did, but a 14% reduction essentially in MACE, a 38% reduction in cardiovascular death, reductions in all-cause mortality as well, and preventing worsening kidney failure as well. But I think as a heart failure cardiologist, I was shocked that we're seeing like a 35% reduction in heart failure hospitalizations in people who didn't even have baseline heart failure. And so these cardiovascular outcome trials, which also included, Canvas was there too, and Declare as well, really brought SGLT2 inhibitors to the forefront and attention of many cardiologists, including heart failure cardiologists at that time.
Yes, exciting. I now feel that SGLT2s, are ubiquitous when it comes to prescription within, cardiology clinics. And, you almost need a reason to not prescribe them anymore, right? Because of a lot of the comorbidities that our patients have and share with other specialties, like you mentioned, nephrology and endocrinology. So, I think maybe I can start off with an example, like a prototype patient in clinic who's diabetic, maybe has mild chronic kidney disease, and is in your office with a diagnosis of heart failure with preserved ejection fraction. Would that patient be considered an appropriate candidate for SGLT2 inhibition?
I mean, in the heart failure space, it's become very simple to prescribe these therapies now, right? Because there are international guideline and consensus groups actually suggesting if you have a patient who's short of breath with a positive NT-proBNP, signs and symptoms of heart failure, you don't even have to wait for the ejection fraction to start prescribing an SGLT2 inhibitor, right? Because we have clinical trial evidence across the continuum of ejection fraction. We even have clinical trial evidence with SGLT2 inhibitors, not just in ambulatory outpatients. We have inpatient initiation data, which is there's more coming in the near future as well. So, I think you said this patient had some chronic kidney disease as well.
Yes, mild. I want to say chronic kidney disease stage 3, maybe. So creatinine in the 1.5 to 1.8 range.
Yeah, a lot of the chronic kidney disease trials with SGLT2 inhibitors also looked at, and this is why I love the cardio-kidney-metabolic space. I learned from my other colleagues with other specialties, is that it's not just about EGFR when you're looking at chronic kidney disease. You also need to look at UACR as well. So, a lot of the chronic kidney disease clinical trials with SGLT2 inhibitors also had patients not just with reduced EGFR, but also with albuminuria as well. And both EGFR and UACR actually predict or prognosticate for both cardiovascular death and heart failure hospitalization as well. So, in this patient in your clinic that you're describing, a patient with HFpEF and probably albuminuric chronic kidney disease as well, it would be beneficial. You're actually preventing heart failure hospitalizations, reducing the risk of cardiovascular death, and slowing the rate of decline of their kidneys as well. So that's a no-brainer for this patient in your clinic and safe in a patient that you're describing as well. We have lots and abundance of safety data for SGLT2 inhibitors. And because they're single dose, they're just so easy to implement in real world practice.
Yeah, so I consider my heart failure colleagues as very smart, particularly for the interventionalist in me. So for someone like myself who's listening to you, the expert in handling these patients and taking care of them, educate us about how you would start prescribing SGLT2s. I mean, is it? I usually go with dapagliflozin 10 milligrams for my HFrEF patients. I don't know if I could start at a reduced dose for HFpEF patients, and dapagliflozin is a similar dose. And then the next question is, or as a follow up question to the first one is, are there any particular drug interactions that you're looking for when you're prescribing these agents for the first time?
Yeah, so both empagliflozin and dapagliflozin, I think people say it differently depending on where you're from, accent a different part of the word, but they're both the same dose, 10 milligrams once a day. That is the evidence-based dose, uh, perhaps for indication of control of type 2 diabetes and further reduction of hemoglobin A1C. There are different doses you can use, but the cardiologist is simple, one dose, 10 milligrams, super easy. Either drug, 10 milligrams. And then depending on the drug that you choose as well, it's down to an EGFR of 30 or 20. I think most nephrologists are very comfortable starting an SGLT2 inhibitor, and they actually continue it down until the point of dialysis as well. So it's definitely safe to continue down to that point. And there are clinical trials actually exploring the use of SGLT2 inhibitors in patients on hemodialysis as well. So to start therapy in that patient population. So very easy to initiate, one dose, no up titration, well tolerated. I traditionally, when I start an SGLT2 inhibitor, I typically check electrolytes in 2 weeks and 4 weeks. There can be a little bit of dip in the EGFR, which typically recovers. If it's more than 30%, it's probably important to look for other therapies or drugs or insults to the kidney. They may be over diuresed as well, because there's can be a little bit of a osmotic diuresis, particularly early on, that happens. But well tolerated in patients both with diabetes and without diabetes. Okay, so this is a medication which if you're treating somebody with heart failure, you can use it regardless of type 2 diabetes status. If they do have type 2 diabetes, it's not really a drug interaction, it's just a consideration that you should think about. When starting an SGLT2 inhibitor, we know that patients should be hemodynamically stable. And there were criteria for in-hospital initiation for the MPulse trial. We can talk about that. But they should also be, and I learned this from my endocrinology colleagues, you want them to sort of be diabetes stable as well. And so people with very high hemoglobin A1Cs, over 9.5, 10, those patients who've had an unexplained DKA in the past, or labile blood sugars, or very, very high insulin requirements, those are the patients that you probably should engage with an endocrinologist with um, prior to starting the therapy. So, very high, poorly controlled blood sugars, high insulin requirements. On an average patient with type 2 diabetes, if they're on multiple therapies, there may be opportunities to remove sort of cardiovascularly neutral therapies like DPP4s, um, you know, um, uh, reduction in glyburide doses as well. And some patients, even with a sort of a moderate insulin requirement, even sometimes a 15% reduction in their insulin dose is something that you might need to think about. But otherwise, really, no really significant drug interactions in our cardiovascular space.
Yeah, no, that's a great overview. And I do want you to also discuss about in-hospital initiation of SGLT2Is. But before we get there, you mentioned stopping or maybe considering a prescription of DPP4s. I used to prescribe them at some point, but ever since SGLT2 data has been so robust in our population, I don't even consider starting DPP4s. But that's a good point. And I never thought of. I mean, I do glance over HbA1c, but I should probably be more cognizant about making sure that they are quote unquote diabetes stable. Before I start them on an SGLT2I.
Yeah, I think it's a good like hint for people, right? To keep you out of trouble. They're so easy to start and very well tolerated, but there are those exceptional patients, right, that you really have to think about. One more tip that people, especially cardiologists, don't think about. Most doctors don't ask about this as well, but in general, because there's a risk of genital mycotic infections, and although the risk of UTI, we don't really see it in clinical trial. I think in real world we kind of do. So those people with an indwelling Foley catheter or using incontinence products, I typically avoid SGLT2 inhibitor. I would have like a discussion with that individual. Certainly, there are profound cardio and kidney protective benefits from this therapy, but there are other issues to consider that can impact quality of life in that scenario. So. Indwelling Foleys and incontinence products, which we almost never ask about in clinic. Our nurses do, but doctors less so.
Yeah, no, this is such a great tip, and I'm assuming you are bringing this up because of the risk of infection, right? If you have an indwelling Foley, or if you're using incontinent products.
Yeah, yeah. That's exactly why. Just it's harder. We know as we've watched the clinical trials over time, genital mycotic infections were something that we noted mostly in the cardiovascular outcome trials, the early ones, right? But we sort of learned with proper counseling about maintaining personal hygiene. An endocrinologist I work with actually tells some people to pee, rinse, and wipe because you're peeing out sugar. And that makes the area prone to genital mycotic infections. And I think in real world, we see a little bit more UTIs, but clinical trials, the UTI numbers aren't all that impressive. But our genital mycotic infections have dropped significantly over time in clinical trials. In fact, they don't even really look for them anymore.
Yeah, no, excellent tips. So, talking about in-hospital initiation, tell us more about that.
Yeah, so I was very honored to be national lead for MPulse trial, which was a study looking at initiation of empagliflozin 10 milligrams in hospital in hemodynamically stable patients and metabolically stable patients as well, who had a diagnosis of heart failure. So there was an NT-proBNP requirement and the signs and symptoms as well. But what was really interesting about this trial, they kind of took all comers. They took de novo heart failure, chronic heart failure, regardless of ejection fraction as well, with or without type 2 diabetes, because it's a heart failure medication. And so, yeah, they had to, as long as they had not been on inotropes for the past 24 hours, had not had an increase in their vasodilators for the last 6 hours, stable dose of IV diuretic not escalating. So, probably not your CCU heart failure patient, maybe more your ward heart failure patient. Or just transferred from CCU patient. So empagliflozin 10 milligrams versus standard of care therapy, and consistent with what we're seeing in the large ambulatory clinical trial heart failure studies with SGLT2 inhibitors. In hospital initiation was shown to be safe, and it was effective as well. Those patients who were randomized to empagliflozin were 36% more likely to experience a clinical benefit. This was a smaller, shorter trial. The endpoint was a win ratio as well. So we knew the strong clinical efficacy and safety data from the large outcome trials in the outpatient population. This was just to show consistency of benefit and fill an evidence gap. And it was successful in doing so in patients, again, which was chronic heart failure, de novo heart failure, and across the continuum of ejection fraction. It was actually fairly impressive. And so there's actually one, I think it's going to be presented at AHA 2025. It's the DAPA Act heart failure TIMI, I think the number 66 trial, very similar concept as well. It's same sort of patient population. And so we always anticipate that it'll probably be consistent. But sometimes there's nuances in study populations, but there should be data coming out with dapagliflozin in the near future for in-hospital initiation too. But I think, regardless of the clinical trials, I think people are doing this already.
Yeah, so I mean, if someone say, I'm just going to give you another example here, because I think I learned better with vignettes. And you say I have a patient who comes in with, I want to say there is history of AHA stage B or stage C chronic heart failure. Now comes in with acute decompensated heart failure, is SGLT2 inhibitor naive, has been on lisinopril, metoprolol succinate, spironolactone as an outpatient, and now you're considering, it was not being seen by a cardiologist for several years, and now we know that we now have fantastic drugs, more data have accrued. Now we have, sacubitril valsartan, we have SGLT2Is. How do you go about modifying this patient's medical therapy whilst he's still in hospital?
Yeah. So I would, especially while they're congested, switching to sacubitril/valsartan, which has the neprilysin inhibitor is a bit of a diuretic impact, and starting an SGLT2 inhibitor as well is great and safe to do in hospital. We have clinical trial data for both of those for in hospital initiation. So you want to watch their EGFR. I guess or creatinine is more what we monitor in a hospital than EGFR, but yeah, it should be well tolerated. Obviously, empagliflozin and dapagliflozin, they don't really have too much of a blood pressure effect, not like sacubitril/valsartan, which can have a much more substantial hypotensive effect. So it would depend on blood pressure, it would depend on potassium, and it would depend on creatinine. And I mean, obviously, as long as the patient's not in shock in any way, either of those therapies would be reasonable. We have a little less data for if this was a really advanced heart failure, on the verge of heart transplant. You're going to try with your best disease modifying therapy, but not great outcomes with sacubitril/valsartan in very advanced heart failure patients that are, on the verge of mechanical support. And probably SGLT2 inhibitor is reasonable. Although, for all of these ambulatory or inpatient clinical trials, the number of patients who are NYHA4 is relatively low, except for the dedicated sacubitril/valsartan trial. So, but yeah, you want to give, your patients the chance at access to disease modifying therapy, and perhaps not as much in the US, but certainly in Canada and perhaps other regions of the world. This in hospital touch point is such an important element of implementation of disease modifying therapy. In Canada, I'd say, we're maybe 40% of patients with heart failure get access to a heart function clinic, where we know the best, uh, targets are achieved for evidence-based therapies and guideline-directed medical therapy. But the majority of patients may never have another touch point with a heart function clinic. Community cardiology does fairly well at prescribing these therapies as well. But perhaps just a step down from heart function clinics that have these multidisciplinary teams and easy access. So anything you could start in hospital is it's so important for changing the prognosis of the patient in front of you.
Yeah, no, what an excellent synopsis there. So just moving our conversation away from heart failure. I mean, I see a lot of patients with aortic stenosis, or I want to not only limit it to aortic stenosis, but also valve disease. So mitral regurgitation, aortic stenosis, and an important accompaniment to this valve condition is diastolic dysfunction. Do you see, so I've come across papers where, authors have demonstrated maybe a mortality benefit in patients with aortic stenosis in whom valve's been replaced. Now SGLT2I should be prescribed. Do you see that in your practice? I mean, do you see diastolic dysfunction? I don't know how to put this. I mean, if there's diastolic dysfunction and if they come in with, symptoms which are indicative of heart failure, I guess it's HFpEF. But maybe there is a subset where you don't want to call it HFpEF just yet, and it's still diastolic dysfunction with valve disease. Do you prescribe SGLT2Is, or it's too far gone? I mean, it's easier to just prescribe them with SGLT2Is.
So this goes along with your statement, like it's hard to find a patient that you shouldn't prescribe an SGLT2 in a cardiovascular practice, right? And so I think there probably could be a potential benefit. I think there may actually be clinical trials going on with aortic stenosis. Not, they could be smaller, just to kind of get some data on it. I'm sure there's been some other analyses suggesting a benefit. I mean, it's in all sorts of like there's meta-analyses in cardio oncology now to support the potential use from smaller prospective studies. So I don't think I'd fault you for it. There's some data. I know some Verma, my fellow Canadian, has done some MRI studies, which showed, at least in patients with type 2 diabetes, there's, some modeling that happens, even though there's no SGLT2 receptors in the heart. So I suspect that, with the cardio kidney, feedback loops that SGLT2 inhibitors modify, that there could be at least a functional benefit, either whether it be from diuresis or changing filling pressures. Um, I, 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 I think it would be reasonable. Patients, particularly with aortic stenosis, are short of breath. You're probably going to have a positive NT-proBNP. I don't think it would be harmful to try an SGLT2 inhibitor in that scenario. And most often, you're right, their echocardiograms come back as well, reporting some form of diastology abnormality as well, which would qualify them for a structural diagnosis of HFpEF as well.
Yes, I mean, again, to just not to belabor, but simply to say that it's hard to not find a patient who will benefit from SGLT2 inhibitor prescription. So I'm going to ask this. This needs to be discussed because it remains at least the bane of my existence here when I'm seeing patients in clinic, is to get these drugs paid for by insurers and third-party payers. What is your experience in Canada for these drugs in terms of reimbursements?
I think Canada, unfortunately, has regional indications for drugs, which creates these in a universal health, coverage country. We still have gaps in access based on the region that you live in. Therapies are approved by Health Canada, recommended for specific indications through CADIT. And then the provinces further get to decide other nuances required. Like in some instances in the past, we've required NT-proBNP, natriuretic peptide testing, but not all provinces have that covered either. So I say we're very creative here for looking for indications in the patient in front of you. We're not just treating the heart, we're treating the kidney, we're treating their type 2 diabetes as well. So I think most regions of Canada have empagliflozin covered for type 2 diabetes. Some have it covered for heart failure. I'd say the majority, but there are some where heart failure itself isn't covered. Dapagliflozin, I think it had a similar journey. It's now generic here in Canada. And, I think we're going to see, an evolution and an increase in access to these therapies as we're seeing increasing generic formulations come out. As another discussion, there's a lot of combination therapies coming out with SGLT2 inhibitors as well, which may also improve, I guess, implementation potentially, or even clinical outcomes. But not the greatest. It's always challenging to access these therapies. And, SGLT2 inhibitors, particularly in HFpEF, they were the very first pillar for a long time that we had. It was our first ever evidence-based therapy, which improved outcomes in patients with preserved ejection fraction and mildly reduced ejection fraction, right? HFrEF, we had 4 SGLT2 inhibitors, was our only pillar for the longest time. So, we really need to advocate on behalf of our patients for access to these therapies in a timely manner.
Yeah, I mean, I couldn't agree with you more. For the longest time, we were throwing the kitchen sink at our HFpEF patients and nothing was working, or at least any mortality benefit. And now you have an agent, lo and behold, and, we're still struggling in finding these agents to be affordable for our patients who need them the most. So No, I mean, we can talk endlessly about this, and hopefully there's a solution. Hopefully we can find a solution for our HFpEF patients and ubiquitous prescription of SGLT2 inhibitors. In terms of, I know you mentioned the cardio, nephro, endo axis, which is, I think, going to be the next big frontier for cardiologists is to partner with our endocrine and nephrology colleagues. How important you see that collaboration?
I think it's so important. We learn from each other. Your patient in front of you doesn't just have heart failure; they likely also have prediabetes and undiagnosed chronic kidney disease. In married to a nephrologist, and I gave a talk at the HFA meeting this year and had this great slide, and it was the kidney is the window to the heart, and the window opened up, and everybody applauded, right? So it really is the window to the heart. With UACR and EGFR. Uh, Prognosticating risk of a future heart failure, hospitalization, and cardiovascular death. That's important to recognize. The mechanisms by several of these therapies in the cardio-kidney-metabolic space often overlap with both cardiac and kidney benefits, plus or minus, improvements in body mass, adiposity, and so the link is significant. I think that the most impressive intersection is probably HFpEF and chronic kidney disease. We're seeing similar pillars developing or therapies for consideration of use. I think it was, just today, the American Society of Preventive Cardiology put out a statement for prevention of heart failure. SGLT2 inhibitors were there across the stages of heart failure. There's discussion about the role of GLP-1s in improving symptoms in patients with heart failure. And in other studies, we've seen reductions in cardiovascular events as well. And so I think that the SGLT2 inhibitors, along with the GLP-1 containing therapies, have a lot of overlap in this PAF space, as well as chronic kidney disease. And it's exciting to see it all evolve, and really make some significant improvements in the functional status and outcomes of like the whole person, right? Everything from arthritis and weight and reduction in cardiovascular events. It's just, I don't know, it's so exciting, to be in a room with a nephrologist and endocrinologist and talk about where these trials are going and the benefits that we're seeing. And in fact, there's even cardio-kidney-metabolic fellowships developing now, where people from all these backgrounds, and probably, even primary care makes sense to be there as well, right? To sort of learn about this important intersection and how to reduce the residual risk of your patient by prescribing therapies like SGLT2 inhibitors that have benefits all across the board for the patient in front of you.
Yeah, no, I mean, absolutely. I think, no matter how much we train cardiologists and nephrologists and endocrinologists, we would not be able to see all the patients who are beneficiaries of these therapies. And so, we have to partner with our primary care colleagues, and they need to be very comfortable and facile in prescribing these agents. No, this has been a fascinating conversation. Final few remarks before we end today's show. Is there anything which we have not discussed about these agents?
I think there's a lot of exciting clinical trials coming up in the future, where we see that SGLT2 inhibitors are being combined with aldosterone synthase inhibitors and other non-steroidal MRAs or MR modulators as well. to both prevent and treat heart failure. So this isn't the end of the story of SGLT2 inhibitors. As they go generic, there's going to be combination therapies that may very well even outperform the outstanding improvement in outcomes we've seen in patients with heart failure and chronic kidney disease and type 2 diabetes. There's certainly more to come, I would say.
Yeah, awesome. Well, this has been a great discussion. Thank you so much for your expertise and your time and your passion for heart failure. I want to say heart function, not failure, as Anu calls it, and all of you call it now. I think it's a better terminology, anyways. And I really enjoyed, our conversation. I learned a lot in terms of the nuances and the finesse with which you can prescribe these agents, and I'm sure our listenership will learn as well. And if for those who are listening, if you have questions, feel free to write to us, and I can forward those questions to Dr. Zieroth, and she'll be more than happy to respond. We'll leave her contact information on our show notes, as we do for other guests. The email address, and do share your feedback with us. We take it very seriously. And if you want to hear from other experts like Dr. Zieroth, just do write to us, and we'll do our best to get them on our podcast. And thanks for tuning in. And until other Monday, thanks, and see you next time.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.